course, if you will, today, the things that are really important to cover. So I've tried to adhere to that as best I can, but also tried to make it practical and useful for you guys. There'll be some topics that we cover in a bit less detail than others because probably not that relevant to you at this stage, and they might maybe confuse things a bit more than necessary. So I've taken a little bit of license and tried to weight things to where I sort of feel that they might be important for you, and also to try and help keep you interested, because I can completely understand that this is a topic that for some of you it might seem quite abstract. There may be some of you who want to pursue psychiatry, whether you know it or not just yet, but there may also be quite a few of you who mightn't go back to this at all and might really end up revisiting these aspects in your medical or surgical careers. So what I've done is try and tailor to that, make sure that it's ideally practical and it makes some sort of sense to you. And it might just help you give you a little bit of insight into some of the dynamics that you see playing out in the doctor-patient relationship years down the line. It's a really, really helpful thing to understand a little bit about, regardless if you're going to go into psychiatry or not. So yeah, this will be the outline for today. So I'll just jump to this one. This is what we're going to talk about. These are the main ones I've been asked to speak to you guys about. And I know that this just probably looks like a few long words and a list of letters as well. We'll be able to go through those and try and help at least make some of these three-letter acronyms come to life as much as they can do in a short Zoom class. If there's any questions that you have during this, please just shout out. I'm really happy to try and make it work for you guys. So if there are any clinical scenarios that you've come across on your placements that you might want to link into some of the questions or some of the therapies that we're talking about, just shout them out. I don't mind any interruptions. We'll try and keep this quite informal. Okay. So when we think about psychotherapies, before I really go into what the definition and the types of them are, these are the kind of, I suppose, the reasons why we should talk about them. You're all finishing medical school. You're all getting ready to start your first year as house officers pretty soon. So it's important to kind of think of the types of treatments that we have in terms of mental health. If we consider psychotherapy, as we should, to be a very valid treatment alongside the other interventions that we use, such as medication or ECT, it's really important to consider it in a prescribing way so that we actually do this with logic and with some structure around it. It's important to know what you're prescribing in terms of a therapy. It's important, as anything, to know when it's appropriate and when it's likely to be effective, and actually what you're targeting in that type of therapy. So what are the target symptoms and what's the time frame that you hope it's going to be effective over? It's really important to know what type of person or what type of illness or conundrum or dynamic might respond to certain therapies, and as well, what therapies are not the ones to choose. So yeah, I hope we'll be able to kind of touch on these things during the talk today. So psychotherapy itself, maybe the simplest way to think about it is two people sitting down and talking things over. That doesn't aim to do it a disservice or to be reductive by any means. It's just really a way of trying to think about it in its most simple terms. It's probably something that's happened for a very long time between humans, where one person has had difficulty and they've sought the attention or the perspective of another person. And that other person's tried to listen, tried to understand it, maybe even try to put themselves in that person's shoes and understand what they would do in that situation, and maybe try to offer them some simple advice, or maybe even less than that, but sometimes more importantly, just to offer them their support and their emotional containment. You might have heard the old adage that a problem shared is a problem halved. I think sometimes that can still ring true in what we do today. Whether that's on a casual personal level when you're kind of just helping friends out with difficulties that they have, or in a much more formal, systemic way whenever we're talking about these as treatments in a mental health service. So it's the attempt to alleviate distress and suffering. It's really the essence of medicine, and this is no different. People who practice psychotherapies, they don't have to be very, very formal psychotherapists as maybe it would have been imagined in the past, and it's done by a range of people, especially because the concept of psychotherapy has gone from what was once quite a sort of abstract art form, quite time consuming, and had to follow certain schools of thought. It's been now changed into much more of a manualized, broken down piece of work that can be learned by practitioners on courses, and can be delivered not just to individuals but to groups as well. So you'll see nurses, social workers, occupational therapists often getting trained up in different psychotherapies. So not just the traditional psychiatrists and psychologists. The aim of psychotherapy is obviously to deliver this form of distress relief and suffering relief via an articulated theory. And an articulated theory is, I suppose, the whole thing about that is that it's aiming to show that there are distinct and organized parts to a concept that actually help it form into a coherent whole, and that it's not just a sort of random, made up on the spot supportive approach. That the whole idea there is that it guides the rationale for using it, and that it's justifiable because you can actually trace it back to a proper theory that seems to make some sense. What we understand as well about how people learn, there are different theories about learning and about the acquisition of knowledge. You may have heard of things like epistemology or hermeneutics, but really to think about it more simply in some of the more modern theories that are used here. And codified learning is sometimes spoken about. I'm not sure if any of you have heard of that. It's just really, in the simplest terms, we all learn stuff when we're growing up. Sometimes that stuff doesn't turn out to be too helpful because maybe it's been, unfortunately, being learned under difficult circumstances, and maybe if it's a learned fear, for example, that might prove to be quite maladaptive whenever we're older and get in the way of our adult lives. So the whole concept is that we actually have the ability to unlearn that and then to relearn new, more adaptive and more helpful material and knowledge in place of it. You may have heard sort of some differentiations, like the types of knowledge that are out there, like explicit knowledge and tacit knowledge. Probably not worth us going into that in too much detail in this talk, but really it's just that explicit knowledge is the one that we think about in codified learning, where we're not just using we're trying to bring things together so that the knowledge is actually transmitted in a formal, systematic language, rather than just the intangible personal quality of insights and intuition that we would probably more readily go to if we were discussing these things more casually. So this slide just has a couple of photos to try and help put some faces to the names here. Sometimes it's useful just to actually know what these people look like. You'll see, and I've done this in sort of chronological order just to try and show, maybe this is just a guess, maybe how the evolution of psychotherapies is gone. And it's a little bit tongue-in-cheek, obviously. We've got the witch doctor or some sort of shaman up in the top left. It's just really, I suppose, to represent that societies or cultures or tribes or groups have always maybe had these wise people within them, whether they are self-anointed or whether they are anointed by the group, given some of the qualities that they might have as a leader or perceived wisdom. They end up being the person that people will go to for help and assistance, whether it be with a dilemma, mental anguish, or some fears or worries that they have. The witch doctor, shaman, or wise person might offer a cure in a physical form, maybe a potion or something like that, or they might offer some sort of ritual, or even they might actually just offer their presence and their calm listening ear to allow the person to speak about their problems. As societies became a little bit more organized and religion came to the fore much more over the last number of millennia, you would have seen the emergence of the priest fulfilling that role and taking on that responsibility, maybe excluding and pushing out the more, if you will, the more pagan offerings that people like the witch doctor might have had, and actually putting all of this through a theological understanding so that all your problems could be solved via, whether it be God, Allah, whatever it is. The priest was also a really important part of the community, and it was someone that people sought out for their difficulties, and they would have gone to, and they would have been offered, whether it be therapy in the form of prayers or in the form of various kind of healing talks. The guy in the middle, I'm not sure if any of you recognize his name, When you've been studying for your medical finals, you've probably maybe come across things like Charcot-Marie-Tooth or Charcot's triad. He's a guy who's really considered to be the father of modern neurology. He's really important to our discussion here about psychotherapy because he was one of the people who, I suppose, really did a lot on trying to bring the concept of hypnosis forward, and that was one of the early psychotherapies, if you will. He was actually a neurologist and an anatomical pathologist. To actually sort of give you a sense of the variety of this person's skills, you maybe just have a look at his history and how much he's been involved in. He was someone who worked very hard on sort of aiming to use techniques such as hypnosis to try and help cure what he thought was hysteria. Initially, he would have put hysteria down to a disease of the nerves, so seeing it as a biological, anatomical problem. But later in his career, he felt after a lot of work that it was actually more of a psychological condition. And he was one of the first people to sort of describe what we now know as something like an anxiety, a depressive or neurotic disorder, actually ascribed that to having psychological underpinnings and not just solely biological. He was quite influenced by Franz Mesmer. Not sure if that term rings a bell to you, but if you consider where the term mesmerizing came from, that was some of the early influences that Charcot had. He was able then to do a lot of work and actually influence people who come later here. As you see, Sigmund Freud. Freud used quite a lot of hypnotism and the notions behind it in some of his early work. But then he went on, obviously, and he's probably the person you've heard of most in this group. He's obviously very famous in pop culture, and a lot of his terminology has been brought forward and still sort of used. But really for Freud, he tried to develop things a little bit further, and he had the concept that people had these unconscious, if you will, urges and drives that drove them, and that they were then the creation of the ego, the id, and the superego, which we'll talk about later. His whole concept was to try and bring the unconscious into the conscious and help through a cathartic process to resolve that conflict with someone, and that will actually help their mental illness. We'll talk about him a little bit more, but this is just, I say, to give you an idea of who the people are. The nice, warm, fuzzy-looking guy with the nice jacket and bow tie and the grey hair is Aaron Beck. He is the person who conceptualized and popularized CBT, which is probably the most widely known and widely used of the psychotherapies. And then above him, you have Marsha Linehan, and she is the person responsible for dialectical behavioral therapy, which is a highly manualized structured therapy that's often used for people with personality disorders. And we'll talk about that towards the end. So maybe that was or wasn't helpful for you. Sometimes it's useful just to see a few pictures and to put some faces to the names here. We'll get into it now and talk about the therapeutic relationship. This is probably where the efficacy of any psychotherapy hinges, and some might also argue the efficacy of a lot of the medications and other things that we use in psychiatry. It's really important that we talk about it, and it extends well beyond psychiatry into medical and surgical practice. It's all about how we conduct ourselves with our patients and how we balance the needs of the relationship. So essentially the strength of it seems to have a correlation to outcomes regardless of the type of psychotherapy that you're choosing. That may sort of be seen in a way to diminish the efficacy or the utility of different psychotherapies, but probably the way that we'd like to see it is that actually it reflects just the importance of the interpersonal nature of the work that we do. The fit between therapist and patient is something that is often focused on. That, maybe due to resource constraints, isn't something that in the public sector we have a huge amount of say about, because often the patient will see the next available therapist or the next available clinician. But certainly if a therapy hasn't been working well for someone and they're not getting the type of response that they or the clinicians would like, it's always worth actually revisiting the fit between the patient and the therapist. So to see if maybe trying a different therapist, whether it be even a different gender, different age, whether it be someone with a different personality or a different style, whether that actually helps maybe unlock things a little bit more and make the patient more comfortable. part of the therapeutic relationship is the sick role. I'm not sure if any of you have read anything about the sick role. If you haven't, I'd really encourage you to. There's a lot of work being done by Parsons in actually kind of describing and realizing what the sick role is. It permeates still, well, I think there's a lot of the interactions that happen in a hospital or in a clinic or in a GP surgery on a day-to-day basis. And that is that a person feels unwell or has some symptoms that stop them from doing something in their lives. So they have the symptoms, they have the functional impairment, they have the distress. They actually then seek out some help for that. So they, for this example, go to see their doctor. They go with an expectation that that doctor has the expertise to help them. The doctor, let's say, plays their part, ideally has the expertise and offers a suggestion to the person, whether that be in the form of a prescription for medications or a type of telling them to rest their leg for 2 weeks or doing some psychotherapies in our case. And the whole part of the deal is then that the person becomes the patient in accepting that intervention, because they should want to get better and they should want to return to functioning and take over their normal social role. Things do tend to get a little bit tricky though, and this is where reading up on the sick role is really helpful, because you will often find that there are some patients who struggle to keep up the latter half of that concept of the sick role. Some of them may not want to or feel ready to return to their normal social roles. So some of them may not actually take on board the treatment plan that you suggest or do things that you're suggesting. It can be for a number of different reasons. And it can sometimes actually be to do with their, in our case in mental health, it can often be to do with their insight and their actual acceptance that maybe there is something wrong that needs help with in the first place. So yeah, I think that's a really useful thing. If it was like something to read up on after this today, Parsons would be a really good way to go. Freudian psychoanalysis is probably a good place to start. I tend to divide this talk up into 3 parts, if you will. There's the psychoanalysis, which is probably the more original, stricter form of psychotherapy that we're going to talk about. That then bridges into psychodynamic psychotherapy. That really is trying to use different types of psychoanalytical and psychodynamic processes to inform how you go through therapy and manage a patient, and that, if you will, bridges some of the older aspects of this to the more modern, and then we move on to the more, if you will, the more manualized and more broken down forms of therapy such as CBT, ACT, and DBT. We'll start really with Freudian psychoanalysis. I mean, before I kind of go into this in a little bit more detail, has anyone here heard of Freud, or anyone kind of actually like know anything or read anything about him? That's okay. You may have heard things like people using terms like Freudian slips, which is seem to be kind of a bit of a window of opening into the unconscious, which is when we're maybe quite tired or we're maybe distracted and off in a daydream, and someone asks us something. Like the classic one is whenever you're in primary school and the teacher asks you something and you snap out of your daydream and you call the teacher mum or something like that. That seemed to be a Freudian slip at times. And there are other things that are commonly used with that as well. Typically they're quite embarrassing, and they're often seen to maybe represent you daydreaming of things that are maybe in a more slightly sexualized or a more relational way. Other things that Freud is famous for are, like, I suppose, the popularization of the term ego. That has been, I suppose, maybe taken out of context a lot, really, and it's used in a very different way now. If you were to hear someone say that, I don't know, John has a big ego, that would be typical of saying that they're very full of themselves, or they're very boastful, or they think far too highly of themselves. That doesn't really represent, I suppose, what Freud's concept of the ego was meant to be, and we'll maybe clarify that as we go through. And simply though, he was a neurologist who trained up as a psychoanalyst and really developed psychoanalysis to the sort of force that it became. He started off with this concept of the topographical model of the mind, and that was to think about it in 3 levels, that our thoughts reside in the unconscious, the pre-conscious, or the conscious. To help with that, if you consider the unconscious being the part of our mind where these thoughts lie very, very deeply, and we're actually not even aware of them. So we can't call them forward into another aspect of the mind and actually think about them consciously. They're right the way back there, and we just don't know they're there until something forceful happens and they come forward. The preconscious is this intermediary, really, where the thoughts, ideas, impulses, feelings, whatever they are, where they're not quite there in the front of our mind and we're not quite aware of them all the time, but we have a suspicion that they're there, and we can actually bring them forward if we think hard enough about them and search hard enough for them. So certain maybe social contexts, or maybe if someone's asking you to focus very specifically, that can help bring those things forward. And then finally we have the conscious realm, which is really whenever stuff is right there in the front of your mind and it's very available. We understand it, or at least we think we do, and we're able to work with it. Part of the treatment, if you will, of psychoanalytic therapy is to try and help bring unconscious conflicts or repressed thoughts from the unconscious through those other realms, the preconscious and to the conscious, so they can actually be worked with. And actually, by bringing them forward, quite often it can be an emotional experience for the person, or sometimes even quite triggering and quite difficult. But there is often seen to be, or it's felt by proponents of psychoanalysis, that this is a form of catharsis, which I'm not sure if you've heard that term before, but it's just a real deep release of emotion, feeling, pent up urges. And that catharsis itself is actually very therapeutic in their eyes, and that would help neutralize some of the neurotic symptoms that the patient might be suffering, such as anxiety or depression. That model that Freud had, it was helpful, and it seemed to start things off for him, but he did face a little bit of criticism, that it was struggling to really explain some of the more complex things that were going on. So he ended up having another model, which was the topograph. The first one was the structural, by the way. This one's the topographical model. Sorry for that confusion. And this was something that was felt to relate a little bit even more easily to clinical practice. Some of you may have heard of this as well. Before I click onto the slide, just to check if any of you want to mention it at all. Have any of you heard of the id, the ego, and the superego? And if you have, do you want to maybe say what you know about them and we can work with it? Okay, that's all right. No worries. We'll bring it forward anyway and just see what you think when you read these anyway. If you start in the middle and you look at this little, I think it's a diagram of a speedometer revving pretty highly. This is the id. So it's not the ID, it's pronounced the id. It represents the primal drives, the deep base urges that we have inside us. Now, these are things such as sex, hunger, fear, safety, desire, jealousy, all of these things. I sometimes almost think of the seven sins whenever I think of the id itself. So Freud would say that we all have this massive internal primal drive inside us. And if we allow this to go, if you will, unchecked, then we would struggle to live humanely in a society without chaos and drama, because you could imagine we would all be taking what we want straight away, doing what we want straight away, and we'd all probably be trying to satisfy our own urges above any other consideration for other people. So the cohesion of society would be lost and people would constantly be in conflict. What Freud would say is that then there was a counter made to that, which would be the superego. If you see to the right-hand side, the mind's external moral gatekeeper. Think of that as the inner parent. So maybe the overcritical voice of a parent telling you, no, you can't have that straight away. You should be ashamed for having those urges. You need to behave yourself. You need to, whether it's don't do that fun thing, or no, that's not allowed. We don't do that here. All of those sort of things that you might have heard as a child when you're being scolded by a parent or a teacher. Freud would see that as being quite similar to the superego. And really we all have this to some degree within us. The idea is that helps balance out the id, but what you're often left with are two competing tensions. The id wants to run away and do whatever it wants. The superego is trying to shame you into not doing that. And if you conceptualize it as those two opposing forces creating a lot of tension within your mind, that's where the ego comes in, because we can't always live with that tension and that conflict. It would be too hard on us, and we would almost be paralyzed and unable to make any decisions or do anything. So the idea of the ego is that it's there to represent reason and common sense. It's there to find a compromise and find a suitable way forward, so that whenever we're faced with a social or personal decision or action that we have to take, we're able to choose something that satisfies our base urges just enough to kind of keep them quiet, keep them settled, to attend to them, but also is acceptable to the superego, so that what we're doing is socially acceptable and doesn't lead us into more harm or more disadvantage. So if you think about it maybe in an evolutionary way, the development of an ego that can help balance out your internal drives and your superego is really quite helpful. It probably allows us to advance ourselves personally, socially, and in relationship ways too. So maybe that helps explain a little bit about what the ego is. It could be that seeing these are all theories. You know, there's no proof for any of these. These are all theories. It could be that just seeing these for the first time adds to your perplexity about psychotherapies and mental health. It's not intended to at all. These are just ways that people are trying to conceptualize the mind. So actually, before we move on to the next one, just something to sort of say about actually the tools that are used in psychoanalytics that sort of make them a little bit different from some of the other psychotherapies we talk about. Freud was very big on free association as one of his early pieces of work, and that was really, he called it the fundamental technical rule of psychoanalysis. It was really the ability to put yourself in a state of quiet and then to report whatever internal observations that come to you. So that can be thinking about absolutely anything that seems to come into your mind once you let it come to a state of rest. His hope was that, I guess, whenever people did that they would stop censoring and stop thinking about communicating their thoughts, because there was always that worry that people were giving a sanitized version of what their worries, their fears, their desires were, because maybe they would fear judgment or they'd fear embarrassment if their fantasies were quite dark and quite sinful maybe. So free association was a technique that was used to try and open that up. And then Charcot himself, like before that, had hypnotism, which was really quite helpful as well. That was trying to, if you will, the theory was put someone in more of an unconscious or a slightly detached state of consciousness where they wouldn't have the typical inhibitions that they would normally have, and they'd be able to go to a place and access repressed thoughts, memories, and bring them forward. It was just maybe the limitation of that would be that the person isn't in clear consciousness once they're being brought forward, and may not have the memory of those things that you've worked on with them to actually make it therapeutic for later. Okay. And we're trying object relations. Has anybody heard of object relations before? No, it's all good. I kind of didn't expect you to. It's not just as well known, I suppose, but I think some of the principles of it would make quite a lot of sense to you guys, and I hope that they will. Something that I found is quite helpful is to simplify it a bit, and it is cheating. It's to take away the term object and just insert people in between, and that helps make a lot more sense at the basic level, because I think the term object can be quite confusing initially. So if you think about it as being people relations theory, it's really just all about the theories of the relationships that we have in our lives and how they adapt over time. It looks to sort of find out and discuss what are the important early relationships that you've had, particularly as an infant, whenever you're starting to understand yourself, and how those relationships and the internal working models of them translate to how you look at current and future relationships as an adult. It really was an evolution from the stuff that Freud was doing. They saw that Freud was focusing heavily on the concept of gratification for an internal drive. And that really, when you look at the people who worked on object relations, such as Melanie Klein, Donald Winnicott, Ronald Fairbairn, they actually wanted to think a lot more that people had an instinctive desire to sort of gain satisfaction from being in relation to other people. So being close to others, being in conversation with them, being in a relationship with them to some degree. And that there was actually this drive for relationships rather than gratification that was more important. The concept, I think, is probably most easily described as it being people forming people having relations with real people, as well as having relations with internal images that they've made of them. So it could be that you have internal images of your mother or your father, brother, sister, best friend from childhood. You maybe have internal images of those people in your mind that you're not fully conscious of. And the images that you have of them not only start to inform you and help predict how you will react to other people later on in life that remind you of them, but also they tell you a lot about your own identity. Because if your images of those people are an image of them valuing you or that you can trust them, that means that maybe you might feel that you are valuable or you are someone who's worthy of trust. And that helps really start to form a lot of your personality and your identity going forward. And in object relations, they would see that the infant's relationship with a mother is the one that primarily determines their personality in adult life. And it places attachment at the foundation of identity formation as well. So the objects themselves that are created, maybe if we try and bring the term objects back in just to debunk that a bit, but the images that I talked about people and events that happen of an infant, if you put into your mind that they are turned into objects in the unconscious, and that the self carries these objects through to adulthood and can relate to them at different times whenever they need to within relationships. So they're there and they're often at work in the background. They often help predict help us predict other people's behavior and social interactions because we have this working pattern or object to relate to anyway. And I'll not drag on too much more about object relations because I do know that there's a bit more of an abstract nature to it and that it might seem just a little bit sort of disconnected from the type of stuff that you guys have seen already. But yeah, it's just safe to say it's really, really well worth reading about, especially if you want to read anything about the sort of work that Douglas Winnicott has done. He was an English pediatrician and psychiatrist, and he had some really, really sort of, I think, resonant ideas about the concept of identity and being good enough. That really focused a lot on children, and it was that the infant themselves starts to form their first part object whenever they're sort of still attached to the mother. So they're so tiny and so small that they don't actually understand that they are an entity of themselves, that they're their own human being right now. They just feel that they're part of a greater whole, which is the mother. And the interface there that's most typical is the breast, because they would be getting breastfed several times a day, and they're so reliant on that for not just for food, but also for connection and nurture. Whenever the infant is hungry or needs settle, if the breast is available, Winnicott would think about it that it's a good breast. So the child looks at this breast and thinks this is good, and that this is something that is always there. But if the breast sometimes isn't available to the child whenever it feels it needs it, then the child is suddenly confused and thinks that this is a bad thing. And that's what Winnicott would talk about as being the bad breast. And I know that these are sort of quite funny, strange terms, but if you think about it really, the child, like whenever they kind of have times when they get the food and nurture that they need, and then sometimes they don't get it, it can confuse the child. But what's ultimately important is that if the child always gets rescued in the end and gets that nurture and learns to tolerate a little bit of waiting around or a little bit of uncertainty, they start to actually understand then that that it will always be okay in the end. That whole idea of a child growing up to be able to tolerate ambiguity and some uncertainty is actually really important for them going out to a big bad adult world where it's full of imperfection, it's full of disappointment, it's full of people not keeping their promises. You can at least learn that not only like is there good things and bad things about the world and about people, but ultimately people are just good enough and you can accept that in a way. So, and we'll touch just briefly on transference and countertransference. I've got some descriptions up there if you guys want to read them. You may already know what these things are. I think it's useful at this stage not to overburden yourself with the different definitions that are there, because there are like very strict psychoanalytical definitions. There are definitions that are much more used by people in CBT for these things. But I think it's helpful to consider transference in an easy way as like how the person feels towards you. So how the patient feels towards you as a doctor. I think that's the most basic way of doing it. And if you want to look into it a bit more, it would be really what the person brings from childhood, like their relationship patterns, their mental images, and what they bring from childhood into this social interaction. And it's sometimes manifested by how they feel towards you. They might feel paternalized, they might feel invalidated, criticized, and they might start, if you will, like letting you know that in some subtle way or not so subtle. And countertransference is there as well, and there are a couple of different definitions of countertransference, but I think that the broader definition is your total emotional response to the patient, which, as it says there, is not just actually made up of what the patient is showing to you or bringing to you. It's made up of your own past experiences as well. So if you've been in similar positions in relationships in the past where someone's maybe felt a bit manipulative or felt a bit kind of rescue seeking or felt a bit entitled, then you'll actually have a countertransferential response to that mirrors how you felt in the past to similar people like that. And countertransference and transference are really useful in therapy, particularly in the sort of more older school psychoanalytical therapies, but really a lot in psychodynamics as well, because the therapist, if you will, takes a longitudinal approach to this. So session to session, they're actually trying to document, record how they feel about the patient in terms of what the patient's brought in transference and what they give back in countertransference. That in a way is quite a good method of trying to see how this person functions in relationships out there in society. So if you're consistently feeling a very negative countertransference to this person, and maybe you could even say finding them quite unlikable, it helps you understand a little bit about how this person's perceived by their family, by their friends, by their colleagues, and maybe why they're kind of getting into constant arguments, difficulties that have brought them to therapy in the first place. So it's a way of kind of, if you will, putting yourselves in other people's shoes. And attachment theory. Some of you may have heard about attachment. Again, I think it's a really useful theory and model to understand. I'd really encourage you to look it up a little bit if you wanted to. And I think it makes a lot of sense to people when we talk about the real early years that an infant has. Certainly maybe the first 18 months as well being a critical time, whenever the child is starting to form an attachment to the primary caregiver. It's typically the mother, but the child can form an attachment to any consistent caregiver who's there, and they can as well form multiple attachments. But for the purposes of a lot of the theory that's out there, it's usually kind of just considered that we think about one primary attachment to the primary caregiver, and that is the one that can have the biggest bearing on the child's attachment style going forward. The reason, I suppose, why this is important in psychotherapy is because quite a few therapies are derived from attachment, and the form of attachment that you develop as a child, whether it be secure, avoidant, or resistant, you can see down there, they do tend to correlate quite well to adult relationship patterns. So whenever maybe you have a patient come to you, whether it be crisis or the GP or an outpatient clinic, and they're having particular problems that seem to stem from relationships, maybe just interpersonal difficulties that are pervasive and repetitive, it's really helpful sometimes to conceptualize it from an attachment point of view and have a look at what was their early attachment pattern. Now, there are ways of, this has been played out in the strange situation test, which is available on YouTube to watch, the original one by Mary Ainsworth, which is a really good way of actually kind of showing how it's done. And it's a series of experiments, often done in videoed consulting rooms, sometimes with one-way mirrors as well for observation, where the mother or the primary caregiver brings the infant in and sits down, and what you do is you observe the interaction between them. And you look for things like, there's a whole series of checklists you can do, obviously, but you're basically looking for how the child is relating to the mother and how the mother is relating to the child. Does it look healthy? Are they seeking out each other's attention? Are they looking to be interactive? Do they respond kindly to each other? Or are there sort of behaviors of concern, like the child seems to be ambivalent or apathetic towards the mother, or even seems to run away or kind of like cower from the mother, as if fearing it, or maybe fearing some sort of response. And then what happens is that a stranger will enter the room and sit down with the mother, and you then gauge the child's reaction to the stranger. And then the mother leaves, leaving the child with the stranger. And it's really important then, because the child should, if the attachment is secure, have quite a fearful response and try and seek to maybe even go to the door to get the primary caregiver back. The whole, we'll not go into loads of detail, it's all available if you want to watch it, but it is really informative actually. And as I say, it translates well into some of the therapies that are used. Before we just do this other section on CBT and some of the more manualized therapies, I'm really aware of the deathly silence that's in the Zoom call at the minute, so I'm probably aware that I've been talking for quite a while. Is there any of that I've gone through that you would like some clarification on, or you have any questions, or is everyone just feeling a bit bored and want me to keep going?
I was just going to ask about the attachment styles, how you just had the diagram there, and there's the three, yeah. Like, are there sub ones underneath those three, like avoidant, resistant, or do you just group them as?
Pretty much there are. So there's one type, there's secure and insecure. So you've got secure down the bottom left. If I'm right, I'm pulling this out of my mind, but I think it's around 70% or 75% of children grow up with a secure attachment. Yeah. And that's really good. The other ones, avoidant, resistant, are there. They are insecure attachment. And then there's also a fourth one, which is known as disorganized attachment. And that's whenever the child clearly doesn't have a secure attachment, but the actual style of interaction that they have doesn't seem to fit well within the other two. And often it's quite rare, but it is quite serious, because I think it's quite a predictor of really bad outcomes. The child will probably grow up into an adolescent and an adult that will really struggle to make any social connections and develop a good, solid sense of identity. It can even be, from what I understand, it can even be associated with bad outcomes, like maybe getting involved with the criminal justice system, or having severe emotional difficulties. That typically happens whenever there have been cases of really bad childhood neglect, or the child has been left with no caregiver for long periods of time, so effectively abandoned in a way. The other ones that are really a little bit more well understood, there's the resistant and the avoidant. If you think of the resistant one, you can see there the box on top is about the child's working model of itself as angry and confused. And you wonder why would a child maybe feel angry and confused. And what that can be due to is inconsistent parenting. So it could be a parent or a primary caregiver who sometimes is really, really nice, maybe even too nice and kind of like overdoing it. And then other times really hostile or really sort of snappy or difficult, maybe scaring the child, and then flips back to the former again, apologizing to the child, trying to make it up. That can be sometimes seen whenever maybe the primary caregiver has strong personality difficulties of their own, whenever there is maybe drug or alcohol use involved and they're going through periods where their behavior becomes really erratic. That can sometimes be seen. And then the other one there, the avoidant style, if you look at the child's working model itself being unloved and rejected, that can occur. That one example that is used often in teaching is if there's a case of maybe really severe postnatal depression where the primary caregiver might be struggling to bond with the child, maybe spending large amounts of time in bed or maybe not able to be with the child, to play with them, to respond to them, might be in a way emotionally unavailable to the child for long periods of time. So the child might feel unloved and rejected and might end up kind of making and developing its own ways of regulating emotions and getting its needs met. So that could be that the child actually doesn't seek out play with anybody because it's maybe learned that nobody's interested or that I'm not worth playing with. And they might develop an avoidant sort of personality going forward or an avoidant attachment style that really informs kind of how they view the adult world going forward. It's really, like, attachment's really good to read about. If there were people that you wanted to look up, like any videos of them or documents like Mary Ainsworth and Bowlby, John Bowlby has been some really, really good stuff there.
Okay, Tom, thanks.
No worries, no worries. You guys, I'm sure I'm not even ask the question because I'm sure you've all heard of CBT. It's cognitive behavioral therapy is the most widespread, commonly used, and probably one of the most adaptable forms of psychotherapy that's out there. And in shifting on to this final part of the talk now, we're moving, if you will, away from some of the psychoanalytic and psychodynamic underpinnings and theories, and we're moving much more now to types of therapy that are manualized. And by what I mean by that is that they're, if you will, quite scripted, and they have like certain sections and parts to them and phases to them that are very well delineated, and you should follow them in that order when you're doing the therapies. They're much quicker and probably easier to learn and to become basically proficient at than the other psychoanalytic and psychodynamic therapies, but certainly still to be good at them and to be effective takes a lot of practice, and supervision is still very important in them. CBT is available in a number of different formats. It's not just a case of like meeting with a therapist and sitting down and doing your sessions of CBT over a few months. It's actually like online CBT has become huge, especially accelerated by the COVID pandemic and us needing to, mental health services needing to, and public health services needing to bring therapy in an available form to people without human contact in the same room. So online CBT is massive, and there is really good evidence for it. It's still being very effective. And in fact, there are some people who actually prefer the online modes of CBT. It can be used for so many different things. There are CBTs for phobias, CBTs for eating disorders, CBTs for obviously the main ones, anxiety and depression. But there's a huge amount of stuff out there that CBT can be used for. So it's very adaptable, and it works on the basic premise that our thoughts, behaviors and emotions are all interconnected. And by providing really good psychoeducation on the links that are there and using practical examples with the patients when you're doing their therapy, you can help them realize how this cycle is happening. Probably most easily conceptualized with anxiety whenever you're taking a patient through it. And it can be so powerful. And what we do, what's done is often trying to identify things like cognitive errors. I've put a few of them up here. Really interesting. If you take a look through them, I imagine there might be one or two of these things you recognize you do to yourself, probably more so whenever you're a bit stressed or a bit tired. These aren't signs of pathology. These aren't signs that anyone is unwell as such. they're really just more things that patterns and cognitive patterns that are recognized that aren't helpful for us and that we sometimes lapse into whenever things aren't going that well. CBT is all about recognizing these cognitive errors, being able to test them, so to ask ourselves or sometimes even write down what is the justification. Let's say discounting the positive. So the example is, I got my work done today, so what? It's only what was expected of me. So discounting the positive would be that you're actually not recognizing any of the good stuff that you've done. You're just taking it as boring, normal, that you're still failing somehow in life. And what we can do is actually write down a list of the things that we achieved. And sometimes we're surprised at what we have done, or even with the help of somebody else, getting them to more objectively look at it and see what we've done. And then actually when you look at it stack up about what you have achieved during the day, it's not inconsequential, and that can help then ease or correct that cognitive error that you're making. I'm sure maybe there are a couple of things you guys are looking at there that you recognize. There's another list of them here. I think catastrophizing, that's such a common one that a lot of people do. Whenever minor worries can sometimes spiral out of control, and we end up thinking that really, really severe things are happening or that nothing's going to go right at all. And then CBT would teach us to look at the links between our thoughts, behaviors, and our emotions to actually see how that cognitive error plays its way through and how it makes us feel at the end of the day, and how we can start to correct it. There is tons of stuff available about CBT out there. Like, there are really helpful apps if you want to try any of those things yourself. I mean, I think I'm trying to think of what that one is. Headspace app, I think, is one that often uses it, and it's available. It's an Australasian one. But there are lots of different ways that if you want to read up on CBT or kind of even try it for yourself, there are loads of ways of accessing it. Dialectical behavioral therapy. Has anyone heard of that before? That's okay. It's a therapy that's a bit more specific than CBT. It may share a small number of the principles, but and certainly a lot of the psychoeducation around it is very strong. But it's really a little bit more targeted for the type of person you want to use it for. So while I said CBT was a hugely very diverse therapy that you could pretty much use for almost any patient or person, DBT is something that has become much more specific for people with personality disorders. And more specifically than that, again, it would be people with borderline personality disorders. That they in terms of who ever gets diagnosed with a personality disorder, and borderline personality disorders would make up the vast, vast majority. I think it's well up there in the high 90% compared to other personality disorders such as avoidant, narcissistic, anything else like that. So it's quite a serious therapy to undertake, and it takes a lot of commitment. The person typically engages for a year to a year and a half. It consists of individual and group therapy. Often there'll be a clinician available on the phone to the person out of hours, which is quite a commitment for the service to make as well. And they have a hierarchy of what they want to work on first of all, because these patients, I'm not sure on your placements you've seen many people with borderline personality disorder on the wards, maybe admitted through crisis as such, but probably one of the most obvious things that sticks out in their admission history is that the presenting complaint might be suicidal ideation or threats or a suicidal act or deliberate self-harm in some way. And so what DBT seeks to do is start off with things, even when they're quite bad, and start working on the life-threatening behaviours. And then once those are sort of helped to be under control, then you start working on other things such as therapy interfering behaviours. And then once you're working on those, then you can get down to the core of the therapy, which is all about teaching mindfulness, interpersonal effectiveness, distress tolerance, emotional regulation. I'm very aware that those things are probably just words to some of you at this stage, or even buzzwords. Interpersonal effectiveness, it's just really about kind of being better at being a person, interacting with others. it's something that can be really challenging if you've got a personality disorder. You maybe can't read other people's emotions very well. Oh, sorry. No, it's not that you can't read other people's emotions well, but you can't react to other people's emotions as easily or as smoothly or as helpfully as you want to. And maybe you're not very good at actually getting your own point across and advocating for yourself. So you can often find yourself disadvantaged in social interactions. And distress tolerance is all about holding the ability to having the ability to hold difficult emotions without completely blowing your lid. And then emotional regulation is the skill and ability to bring those emotions back into check once they've kind of got out of the box, to calm yourself down and hopefully not go to the more extreme ends of regulating your emotions, such as cutting or suicidal threats or risk-taking behaviours, trying to find really sort of safe ways of managing that. And the strategies you can see down the bottom, like dialectics, which is what dialectical behavioural therapy is all about, and it's probably a word I should have explained at the start. It's about walking the middle path and being able to hold two ideas, two sort of competing things around having your emotions. Essentially, like what ends up happening is that there's a lot of validation, a lot of work goes on through mindfulness, and the whole goal is to try and help look at someone and help them understand what changes might be helpful for them to live a life worth living, and to feel in a way more valued in themselves. I know that the time's getting on, so we'll just maybe go through these last ones quite briefly. These are the ones that aren't as commonly seen, so I don't think that you're probably going to need to know or remember a huge amount about them. Interpersonal therapy is something that takes place usually over 3 to 4 months, and it has got very good evidence compared to other therapies, sort of up there with CBT, at working on depressive difficulties that come, what you want is ideally to come from one of 4 particular interpersonal problems or scenarios, and that could be conflicts with others. So that's maybe, like conflict with your family or conflict with people at work. Role transitions, so like a huge one would be becoming a parent or retiring from your job. Those are massive life events. And then loss or grief, such as like losing a loved one, and interpersonal deficits, so persistent loneliness or isolation. Acceptance and commitment therapy. Some of you may have heard of this. It's becoming more popular. The whole idea would be to not challenge the thoughts as much as you do in cognitive behavioral therapy. It's more about actually just kind of recognizing them, helping to put a bit of a label on them and roll with the emotions that come with it. So not trying to fight it too much, just saying to yourself that this anxiety, this sadness is just an emotion. It is only a state created in my mind. It's not a real thing, and I don't have to overreact to it. I can just let it come and let it go, because my experience teaches me that when I felt this way before, it's never lasted for too long, and it can't really harm me. It'll just go. The part of this that's around commitment is one thing that's felt to be actually really beneficial is spending some time with a therapist, going through what your values are in life. For some people, their values surround things like, maybe it's values such as beneficence and trying to help other people. Maybe it's values such as being very socially conscious, or being very loving, or being kind, or whatever those kind of values are. Or maybe for some people it's values of playing right and wrong. And whenever you are faced with a dilemma, a choice, or a difficulty in life, acceptance and commitment values would try and urge you to assess the choice in terms of what would my values want me to do in this, and then follow that choice, and trust in the process that if you continue to make choices based on your values, that it will ultimately lead to things being smoother and happier in life. That's a bit of a pop version of that. Okay, that's fine. Cognitive analytical therapy, or CAT, developed by Anthony Ryle. It as well has a very good evidence base for some personality disorders, and it can be really helpful in terms of having a shared understanding of what's going on for the person. I don't think you're going to need to know a huge amount about this because it's quite specific and there aren't that many therapists, maybe in the public sector, who are that trained up or use it on a sort of day-to-day or week-to-week basis. So that's just probably why you don't see it as often. The last couple of things we'll talk about, one of them is mindfulness. Has anyone got any experiences of mindfulness that they'd like to talk about, or whether they've done it themselves and find it useful? No, that's all good. If you don't know what mindfulness is, there's so many ways to find out about it. There's tons of mindfulness apps. The concepts of mindfulness have been added into loads of things, and even into popular lexicon, such as everybody talking about being mindful of this, or you got to be present, and all these things. So it's kind of everywhere. It's quite pervasive. And John Kabat-Zinn was the person who's kind of brought it to the fore by sort of mixing sort of Asian, Eastern, Buddhist influences with psychological concepts. You might have heard of things such as progressive muscle relaxation. They are really, really helpful. And like mindfulness itself, as a collection of all those different skills that are tried, is really useful for patients. And it's quite a sort of general approach. It doesn't seek to be quite specific. But certainly people who might be struggling with anxiety, PTSD, or maybe depressive disorders might find mindfulness really helpful in terms of grounding them and allowing their thoughts to return to the present instead of always wandering off to some anxious destination. Psychoeducation, that I suppose is a form of psychotherapy. It's probably something that's maybe undervalued in every interaction that we have with someone, and yourselves, whether you go on to work on medical or surgical wards, or you go on to work as a GP, you'll be in a position where you should be delivering really high quality psychoeducation to your patients. That is all around informing them and sharing the knowledge about their medical disorder, how it's going to impact them, how they might feel about it, what the difficulties are. I mean, it's known that certainly whenever psychoeducation is done well, it can promote autonomy and I guess a bit of ownership over someone's health, because they might feel that they now understand it and it makes sense to them. And ultimately, you want to try and build that, because that helps strengthen the patient themselves. It might actually make them look after their health better, or even maybe take their medication or the treatment that you're offering more because they believe in it. It makes sense to them. So it's a really important thing to do. Doctors, I think, have been criticized in the past for being very over paternalistic. So if you will, maybe sort of like relying on the fact that patients trust our words too much. And if we say, oh, just take this, it'll be good for you, or just do this and don't worry why, it's sort of seen that that's not good enough anymore, and that patients do have a right and need to know about what's going on for them, and that you actually have a duty to try and explain to them to the level they want to know, and to a sort of age and developmentally appropriate level, what's going on. I think this is our last sort of explanatory slide, so we're almost done. Just around counselling, I suppose it's a form of psychotherapy as well. It's at its most simplest, it's just listening, reflecting, maybe even reframing. Some counselling tends to be more problem-solving focused, and you kind of try and like suggest things as to maybe how someone could do things to not feel as distressed about them, or to maybe solve some of their issues. But other times it's just about listening and forming a containing relationship with a person to share their emotional experiences, and then maybe start to digest them a little bit in the room and try and make sense of them. It generally is helpful, and people tend to like it, because I think as humans, many of us like sharing our difficulties and being able to have a listening ear. But in a way, if you think about this as a intervention, compared to other psychotherapy interventions that are there, it's quite unstructured, and it's quite open, it's quite heterogeneous, so like it's open to people doing whatever they want with it and providing it in any certain way. Anyone can become a counsellor in New Zealand. You don't really have to have a huge amount of experience, qualification, vetting, or supervision. And in some cases, it doesn't take a lot of qualification or vetting to get registered with the ACC to provide counselling services to people who may actually be better served, you could argue, coming under the sort of primary care or the specialist mental health care services. And there's very little auditing of it and measuring of any outcomes to see if the counselling is provided through those routes is helpful. And there's a whole lot of money spent on it. It's not that counselling is something that can be complication-free. Yes, it might be generally helpful to people, but there certainly can be times whenever maybe ethical boundaries are being crossed without the person sort of knowing it or really recognising it. And patients can sometimes find that their difficulties, their psychological condition can worsen over time because maybe something more severe is going on and a counsellor maybe doesn't have the experience to work with that properly or safely. I have 2 slides here at the end that are just big, horrible, small text tables, and you don't need to look at these in detail. It's effectively, it's an Australian Psychological Society slide that just actually shows the levels of evidence that are available for some of the more common psychotherapies. You'll see them there down the bottom, starting with ACT and going across to solutions-focused therapy in an alphabetical order. And you'll see that they're being graded in terms of their level of evidence 1, 2, 3, and 4 compared to the various diagnoses that people might want to use them for. This is just to show that quite a lot of work does go on in trying to understand what the better therapies might be for certain disorders. It's in no way foolproof. This is the one for child and adolescents. The one up here, sorry, is adults. It's in no way foolproof, of course, and trying to measure the efficacy of various psychotherapies is challenging. It's not as tangible, maybe, as looking at sort of quantitative data for medications or for things like ECT, because there are so many moving parts to it and so many variables around how it's delivered. But it's just to show that there is some reasonable levels of evidence for these things here. That's us. Has anyone got any questions? I'm certainly, to be ironic and to say that I'm very mindful of how different this teaching probably is and this topic is to some of the more conventional stuff that you've had, even within the mental health modules on psychiatric crises or on psychotropic medications. I imagine that those are things that have a huge amount more clinical relevance to you, and that this is probably a teaching session that you may have approached with less interest. I hope it's been helpful to at least kind of talk through some of the main schools of psychotherapy and some of the main theories that are there. Do not worry if you don't get it or understand it, or if it all feels too vague and nebulous for you. I think that's a fairly normal reaction to have when you're confronted with this stuff for the first time. I would just hope that maybe there's a few simple principles that you can take from it that are helpful from a talk like this. And if it has sparked your interest, there is so much good work to be done in psychotherapies, and it's a really interesting thing to learn about.